Good afternoon, guys. My name is Hai Liang. I'm the Assistant HOT of the Department of Education. I am the organizer for this this event, case by case basis. So we hope to make this a weekly thing. But for now, because of MCO and the lack of proper classes, I hope maybe for now we can do like this. Okay, so we invite doctors to come and talk and then give you some clinical insight in this time where you cannot go to the hospital. Okay, so today we have Dr. Lim Wei Kang. Okay, as you all know, he is a pediatrician. Yeah, so he is a very good doctor and one of the best from pediatrics that I know of. Yeah, he taught me from CRS last year. Okay, so without further ado, I'll pass the time over to Dr. Lim lah. Okay, Dr. Lim.
Okay, thanks, Hai Liang. Yes, can you all see my slides? Yeah?
Yes, doctor.
Yeah, can see.
Okay. Yeah, let me just try to move my slide. Yeah, okay. Now, okay, let me know if you don't see my slide or if I'm stuck or something. Okay, so my name is Wei Kang. As Hai Liang already mentioned, I'm from the Department of Pediatrics. But I won't say I'm sort of like one of the best. I'm just one of the pediatricians in UMMC. So, okay, so I need to thank the Medical Society for giving me this chance to join today's session. And the content of this session was entirely based on my very limited personal experience and opinion. It doesn't represent in any way. So, outline. Okay, so this talk is meant for 3.1 students. So if you are like 3.2 or stage 2 or 1, if you find it not so relevant, please bear with me. So I'll just give you an overview of how to take a pediatric history, followed by 2 case discussion. And lastly, I will end my talk with some tips for learning pediatrics. And not just exam. I think this is the most important point that I want to bring up during this session. So how much should you learn? How much should I learn as a student? So this was always a question that I asked myself when I was much younger. So for the UMMP program, there are 3 stages: stage 1, 2, and 3. And then for right now, stage 3, they are divided into stage 3.1, 3.2, and 3.3. So, I always give this analogy to my students. So when you are at stage in the medical school, you are, like taking the L license for your driving test. So, the stage 1 and 2, you just learn the theory, like the theory test for the driving license. As you go to stage 3, like 3.1, you learn how to start the engine, how to shift the gear. So the basic maneuver or how to get the car going. When you go to 3.2, 3.3, you sort of like a bit more advanced, but you still L license. So you do things like, hill test, how to do parking, 3-point turn, on the road test. So once you pass your UMMP, your medical school, you will go into this so-called housemanship. So now you have got P license. Okay, you are like a professional driver on the road. Well, you know how to drive, you can drive, but you have to drive within a set of rules. So after that, you pass your housemanship, you progress to become a medical officer or master trainee later on. So you're like driving this, like Ganchill, but I think Ganchill was already sort of like no longer on the market. But what I mean is, you can drive with full license, but your skills still need a lot of polishing. So once you go into the stage of specialist consultant, so you like your skills can control like a sport. So obviously, so how much should I come back to our question? When you are like in the earlier stage, L license driver, we won't expect you to drive like a F1 driver. So right now, specifically for 3.1, I think you just need to know how to properly take history. What are the correct steps of examination? You shouldn't be missing important findings, important history, but we wouldn't expect you to pick up very subtle or more advanced clinical science at your stage. But when you progress to 3.2, 3.3, then we will expect you to be a bit more advanced. You should be able to pick up some signs which are not so obvious, but be able to elicit it with your clinical examination skills. I think this is what I'm trying to tell you from this slide. Okay, yeah, sorry, yeah. Just move to the next one. Okay, now, okay, let's go to history taking. So why are we taking history? I think the purpose of history taking is very important. Before we learn anything, we need to know what's the purpose of learning the skill. So to me, history taking is to gather more information from patients, or in pediatric, from the caregivers, okay, so that we can try to list down our differential diagnoses. We get some clues how to plan for our further investigation. Very often, history taking is not just to just ask questions. It's also a chance for us to build rapport with the patient and also their parents. When this is very important because we need to make the patients and the parents they can put their trust on us. And how do we do that? Is to be able to take a proper history and then to communicate with them well. And also we can use this opportunity to explore what I mean the ICE model, okay, the idea, concern, and expectation, okay. So this one you will probably learn in your community posting, so I won't really elaborate further. Okay, so what is important in the history taking is, the verbal component, it has to be clear, we have to use simple language, we always have to try our best not using any medical jargon, okay. For non-verbal, okay, we need to show the patient or their parent that we know we are attentive to them, we are caring, and then we need to show some empathetic, and not just saying that, oh, I just need your answer and then that's it. So we need to show them the non-verbal cue as well. And we have to remember, I mean, when I was a medical student, they teach me all the techniques, how to take history so that I can pass the exam. But as I progress further in my career, I find that, history taking is probably one of the most important skills. Doesn't matter whether you are a surgeon, physician, pediatrician, or even, if you do forensic pathology, you cannot escape from taking history. I mean, of course, a forensic pathologist cannot take history from the patient, but he will be able to take history from, witness or the doctors who manage the patient before that. So taking history is not just to pass the exam. It's an important skill that we need to have as a doctor. And then you have to remember that, you shouldn't be passing the exam just by showing showmanship. You should pass it because you have acquired the basics. I think this is very important. So don't just go into the exam and then show people that you can do it, but you must be able to do it because you know how to do it. Yeah. So now let's look at the pediatric history taking. So we start from the presenting complaint first. So remember, a young child cannot complain of a problem, unless he or she. So we should always. Sorry, there's some problem with my slide. But what I mean is, I often hear students presenting saying that, okay, a baby complain of tummy pain. A baby can't really talk. How can he or she complain of tummy pain? So what we should say is, he or she presents with, tummy pain or tummy ache or something like that. So, and then presenting complaint is like reading a newspaper headline. So it shouldn't be very long, and it should be short and succinct, and you should be able to cover whatever thing you want to present later. So for example, this is a 5-year-old kid with a history of epilepsy, presenting with recurrent episodes of afebrile seizures, require bolus, what I call that, midazolam or something like that. So it should be short, but be able to convey the important message and be able to capture your consultants or your colleagues' attention. So after they're listening to your presenting complaint, they will be able to focus more on your subsequent presentation. This is what I mean. Okay, so now we look at the presenting complaint. Then the next thing is the history of presenting complaint. Okay, so it is the details of your presenting complaint, and don't forget the important negatives. And then, as usual, you've got your past medical history, past surgical history. And when you talk about past medical history or surgical history, don't just mention that, when and where the child got admitted. You should try to, can you hear? Yeah, can. Because I heard some noise.
Can.
Oh, sorry. Okay. So for example, when you mentioned about the previous admission, I mean, you should be able to try to ask a little bit further. For example, what happened during the admission? Does a patient go to ICU and things like that? So that will make the history a bit more complete. And then you move on to drug and allergy history, and make sure you ask when patients say they are allergic to some medication, you always clarify with them what were the allergic responses, because sometimes it may just be side effects rather than a true allergy. For example, after I take Augmentin, I have diarrhea. Diarrhea is not really a allergic response; it's like a side effect. So you won't probably stop giving people Augmentin because they have diarrhea, but you'll stop giving them if, let's say, they have like angioedema, anaphylactic shock. Okay, so this is important. Okay, then we'll move on to the diet history. Yeah, I often see students, not just students, even the MOs, sometimes the house officers, they put things like adult diet. This is a little bit too general. What do you mean by adult diet? What you have as an adult, it will be clearly different from what I have. Like, you have like maybe chana lunch, like me, and noodles, as lunch. So we should try to, ask them, what will be the sort of like the main thing in their meals. For example, is it like carbohydrate rich? Is it mainly deep fried food? So we should try to what sort of diet they are having, rather than just putting that adult diet or normal adult diet. Okay, and then you move on to family history and social history. Okay, so for pediatric, this above are just the generic history taking, but for pediatric, you need to do something extra. So you need to inquire about the birth history. Okay, looking into the antenatal, intrapartum, and postnatal period. Okay, don't forget to take vaccination history, whether they have the vaccination on time. If they say they miss or delay, what was the reason, and any side effect. And also, okay, the developmental milestones. Okay, I put an emoticon here, like a scary face, because often people, they really scared, when they come into developmental assessment. So, okay, don't worry. Okay, you just have to do it systematically. So make sure you cover the gross motor, fine motor, and vision, speech and language. When you talk about speech and language, okay, don't forget it has got two components. You have to talk about receptive speech development and also expressive speech development, and also not to forget the social development as well. So the key of taking a good developmental history is to keep practicing, and then check with your milestone chart, and then by doing that very frequent, you will be able to remember what are the important, not to be missed milestones for each age group. Okay. And last but not least, and don't forget to ask a bit about their education, and also hobby. Sometimes I think this will give us a clue, some psychosocial issue that the child have. So I think always try to, ask about their education and also their hobby if you have time. Okay, so now we go to, the system-based sort of approach, so we'll be looking at different measure system, and then what sort of important points when you take history for these systems. So first we look at the cardiovascular system. So the common problems that you can encounter as a medical student, will be things like heart failure, okay, cyanosis. So for heart failure, they'll come with symptoms, like rapid breathing or excessive sweating during fit. This is mainly for younger child, like a baby. Okay, and when you notice they have a failure to thrive, but remember, not all failure to thrive are due to heart failure. So diet history is important here. It could be just due to poor, nutrition intake, and also not to forget about your reduced effort tolerance. So this is like a adult, like a NIHA classification. Okay, so for those with like a cyanosis, you have to ask things about like that. What makes the cyanosis worse? For example, cyanotic spells during stress, dehydration, could be due to TOF, tetralogy of Fallot. And what relieve the cyanosis, by squatting down, the patient get better. So that, this could be like a hypercyanotic spells in tetralogy of Fallot. And don't forget, when you take history, you always need to ask those not to be missed points. For example, in cardiovascular system, if you miss respiratory distress, if you miss failure to thrive, if you miss cyanosis, and things like lethargic, it will have a very serious consequences. Patient could go into collapse state if you don't pick this out earlier. So you should have a set of not to be missed question, depending what system you are encountering. So this, I'm just giving you a guide like how to build the template for each system. So over the years in your medical student career, you will have your own list. For example, like for pediatric CVS, you will have a more extensive list than what I'm showing you here. I think that's fine. So you just try to do things like that, and then you'll be able to tackle most of the pediatric history taking. We move on to RESP system. Common problems are like cough, rapid breathing, shortness of breath. So the difference between rapid breathing and shortness of breath is, rapid breathing is like, what you see, the child is having very fast breathing, but shortness of breath is sort of like, difficulty in breathing. This one we reserve for like an older child who can tell you, they are having difficulty in breathing. Of course, parents come to you with description like, oh, I think the breathing is very noisy. So it could be due to like stertor, stridor, or wheeze. So I won't go into great details of how to differentiate which is which. You should be able to learn this when you have your RESP session in your stage 3 or even earlier stage. Yeah. So if you have problems, you can always drop me a message. I can describe further. Okay. Always identify the trigger to the RESP problem and then the onset, whether it's a sudden or gradual. Don't forget to characterize the cough. So whether it's dry or wet. And the sputum, remember, young children cannot expectorate to sputum. So when you see a baby, when respiratory distress, like 6 months old, don't go and ask the parents, oh, can the child cough out sputum? What's the color? Because they cannot expectorate. They can vomit out the sputum, but they can't really expectorate. And history of atopy, and including the family history of atopy, also important to help us to decide whether this is like atopic diseases, and also the environment. So cigarette smoking of the people who stay together, any carpet, any pets at home, and the dust. And we cannot miss things like rapid breathing, failure to try cyanosis. So it's pretty much like the CVS system. But one more thing is foreign body aspiration. So always try to elicit whether the child has got any possibility to ingest this foreign body. So for gastro system, okay, common problems like tummy pain, vomiting, diarrhea. So this one quite standard. Okay, again, trigger, onset. Okay, whether is it meal related or not. Okay, where is the pain, the localization, pain score. Okay, this is very important. Like if a child can give you a score, always try to ask them what's the score when the child starts to have pain, and then what's the current score now. Just try to get a feel whether this is worsening or improving. Content of the vomiting also very important. So if you get bilious or vomiting, it could indicate like things like intestinal obstruction, a bloody vomiting, it shows something, serious. So you need to, treat the vomiting more seriously. The content of stool and consistency, well, you need to know how to use your Bristol stool chart and how to describe it, because if you don't carry the chart together with you, it could be difficult for you to explain to parents. So you need to know how to explain Bristol stool chart to parents and then get their scoring. The stool color is important to tell you whether this is like a conjugated or unconjugated jaundice, and the bowel habit, diarrhea, constipation, and things like that. So to me, what are the not to be missed point would be things like bilious vomiting, poor or no oral intake, lethargy, or bloody diarrhea. And always at the back of your mind, when you take gastro history, you have to think about the non-gastro causes. For example, diabetic ketoacidosis can present with tummy pain. Dengue fever can present with tummy pain and also vomiting. Head injury, again, recurrent vomiting, and also non-accidental injury. For example, let's say there's a sexual assault, there's a penetration into the anal, you can have some bloody diarrhea. So don't forget to examine the child thoroughly. Okay, now let's come to neuro. Okay, so common problems. Okay, I put apostrophe because things are common may not be very, very common in nature. They're just like a little bit more common when you come to the neuro system. So you have seizure, a floppy child, or the child can come to you with frequent fall due to maybe muscle weakness. So again, standard thing like onset, trigger, but you need to inquire a little bit more when you take neuro history about the functional assessment. So what can the child do before? What can the child not do now? And also don't forget, take a careful and thorough developmental history. So if you handle a child with a seizure, okay, you need to be a bit more detailed when you take their seizure history. So what, like the pre-ictal, any aura, the ictal semiology, okay. So whether this is a generalized seizure, whether this is a focal seizure, post-ictal state, what happened, duration of the seizure, and the frequency, how frequent is the seizure, whether got any fever or not. So things like not to be missed would be, drop in GCS, the child drowsy, not recognizing parents, or recurrent early morning vomiting, severe headache, that wakes a child up from sleep, blurring or vision or change in the vision problem, or someone come to you with acute limb weakness, or whether it is a hemiplegia or quadriplegic. So you have to be able to pick these important symptoms out and then try to find out what was wrong with the patient. Okay, then we go to musculoskeletal system and also skip. So common problems will be like rash, joint pain, refuse to walk or stand. So trigger, onset, again, you have to ask. So for rash, you have to be a bit more specific. The distribution of the rash, where are they found mostly? The shape, the color, whether is it raised, whether there's any blister. So all these things, I think you probably learn in your dermatology, blog, but when you come to pediatric, don't have to, you have a chance to use this again. So like joint pain, you have to ask them how many joints, and then you have to differentiate whether this is arthralgia, just a pain, or with swelling, arthritis. So this is important. So not to be missed will be things like, pathological fracture. So for example, if the child had a fracture due to some trivial fall, then you have to always think of whether this is something like MAI, or this thing like, osteoporosis or some bone disease, bone cancer. Okay, then Kawasaki disease, you must know all the clinical criteria, because I think even though it's rare, but it's something that we tend to see in the pediatric patients. So this one you must know quite detailed. Okay, then of course we have something that cannot be classified under a specific system. So for example, like Down syndrome, Marfan syndrome, and Turner's. So again, this thing, I think especially important will be the Down syndrome, because it's the commonest chromosomal disorder. So you need to know very well what are the dysmorphic features and the related complications, and how do we do health surveillance. So other things that we haven't covered will be things like short stature and developmental delay. So I think for developmental delay, you have to try to decide whether this is an isolated delay or a global delay. Global delay means you have two or more components that actually having delay. So you learn, don't be stressed. You learn all these things as you come to pediatric posting, and then if you are not so sure, you have problems, you can always drop me a message later on. Okay, now I don't know how. Okay, I probably already spent half an hour, so we can probably take a short break if you need to. But I think due to time constraint, we probably have to just move on. But have you got any questions so far, or am I speaking too fast? So far, so good. So if let's say there's no message, then I assume everything is good. I will just move on. Okay, now is the case study. So I will need to, do this with Hai Liang. Okay, so Hai Liang.
Okay, yeah, doctor.
Yeah.
I think there's a question by. Oh, so far so good. Okay.
Oh, okay.
Okay. So today we have two cases. Yeah.
Yeah.
So we have two cases. So I'll read the first one to you, the first prompt.
Okay.
Okay. So the first prompt is an 11-year-old boy named Tan with underlying Down syndrome is rushed by his mother to the hospital. She complained of 2 seizures occurring in the past 1 hour. The 2 seizures lasted 2 minutes and 5 minutes respectively. The 2 seizures occurred within a few minutes of each other. So doctor, what do you think if we medical students encounter this problem, this patient, what should we ask for?
Yeah, so I think again this STEM is not that typical of 3.1 standard, because it contains sort of like 2 pathology. One is a seizure, the other one is like an underlying Down syndrome. But I think even though you get this kind of question, you focus on the acute medical problem first, so which is in this case the seizure. So I think we should take a good seizure history. For example, like asking things like whether this is a first seizure, where before the seizure, what was the child doing? Any aura, like the child appear to be frightened, run towards the mother. Okay, so this will be like so-called some aura. During the seizure, what happened? Whether this one involved the whole 4 limbs or just one of the limb. So you have to ask the mother to describe further, or like whether this is like a jerk, convulsion, or just a tonic posturing, that the limb just gets stiff, any head turning to one side, because head turning could indicate focal seizure as the underlying cause. Yeah, and then also after this, don't forget to ask about things like, after the seizure, so-called seizure, did the child appear to be drowsy? Most of the seizure, if it's a true epileptic seizure, the child will feel drowsy after the event. But sometimes the patient could have just a syncopal attack, like suddenly the child has palpitation, and then after that, what happened was the child just collapsed. So people we think this is like an atonic seizure, but we ask further, after the child recovered, there's no post-ictal drowsiness. So you have to be very careful here. Yeah, this is what I think.
Okay, so doctor, I will just tell you about the pre-ictal and the post-ictal thing. This is a tonic-clonic seizure as described by the mother, uprolling of eye with simultaneous jerking movements of both arms and limbs, both arm and leg. So for pre-ictal, the mother describes the child as being more agitated a few minutes prior to the seizure, but doesn't seem to have any aura, seeing things or smelling things. For the post-ictal, the child just seems more quiet than usual. Can we take this post-ictal sign as drowsiness, or is this not actually drowsiness?
Yeah, I mean, this is difficult because you have to clarify with the mother what does she mean by more quiet than usual, because sometimes they could look very tired, then they probably just sit there doing nothing. So this is, we have to make a further clarification. So what is that? But I think, to me, this one probably is a seizure, because the more quiet than usual thing to me sounds like the child become tired, and then that's why rested for a while. I think this is what I think, but I cannot be entirely sure. I need to just get further clarification from the mom.
Okay, so doctor, about the Down syndrome of the patient. So do you think that this Down syndrome has a role to play in this seizure?
Well, again, Down syndrome. Well, this one is very tough. It's not something that we recognize in Down syndrome. That not like classical things like it's not like hypothyroidism. It's not like things like duodenal atresia. They can have seizure, but whether they have increased risk of seizure or not, I think this one I'm not entirely sure. But as other child, when they have a seizure, apart from taking a history, we need to investigate further. So I think in this case, I wouldn't say that by being a Down syndrome, they have an increased risk of getting this seizure. But of course, we have to ask whether there's any family history of epilepsy, because if there is a family history of epilepsy, then that will increase the likelihood this is of seizure in this child.
Okay, so I'll move on with the past medical history. So the patient has been admitted to the hospital 4 times before this. The first time was 5 years old. Second time, third, fourth time were in the span of 1 year, which is starting from 10 years old until 11 years old. So there seems to be a raise in the frequency of the seizures.
Sure.
What could this mean, doctor?
Okay, first of all, I think we have to clarify with the parents, whether all the above seizures are they of similar patterns or not. Not all the seizures described by parents are true seizures in nature. So I think we have to clarify that. Well, of course, it depends what is the cause of the seizure, whether this is due to some structural brain abnormalities, whether this is, for example, due to some metabolic condition. I think this one will require more investigation to tell us. But as for why the child has got increase in the seizure frequency, I cannot be very sure at this point of time. But what I do know is, I need to do something, to try to find out what is the cause of the seizure before I can plan the next step and then to tell you more about the seizure.
Okay. So you think that there could be a structural... So what is going through your mind right now, doctor? May I know?
I can't remember the simology. Do you mind if you just repeat the simology again? Sorry, I can't.
Oh, okay. So for the pre-ictal,
No, that's.
the mother, yeah,
Sorry, go on.
uh,
Sorry.
yeah. So the mother describes the child as being more agitated a few minutes prior to the seizure. However,
Mm,
when asked, the mother said the child didn't describe having any aura, like seeing
mm,
things or smelling any abnormal smells. So
mm.
during the seizure, mother described an uploading of eyes with simultaneous jerky movement of both arms and legs. Uh, for post-ictal, the child just seems more quiet than usual, but not
Quiet.
agitated.
Yeah.
Yeah.
So what you described the ictal simulology, sounds like a generalized seizure because the child sort of lose consciousness, eyeballs uproll with both upper and lower limbs involvement. So this one to me sounds like generalized seizure. So a generalized seizure, sometimes very difficult to tell whether there's a structural problem. A focal seizure will point more towards, a structural brain problem. But we cannot be entirely sure by just listening to the simulology. We need to do more investigation like EEG to see whether there's any abnormal discharges from a particular part of the brain or not. But I think, as a 3.1 student, even like during the exam, the examiner won't really ask you, what do you think, whether this one generalized seizure, does it mean that the child has a structural brain malformation or not? I mean, by taking a good history, I think that should be enough. I mean, at your 3.1 stage.
Okay. So, doctor, I just want to point your attention to the development assessment before we move on to the next case.
Sure.
For the development assessment, the patient does have a global developmental delay. For the gross motor, the patient could only independently walk at the age of 3, and until now still cannot walk heel to toe. For fine motor, he could only do tower of 3 blocks at 3 years old, and currently is still unable to imitate drawing an X or a diamond. For language, the patient can only speak in 3-word sentences even until now, and he only started speaking at the age of 6. For social, the patient don't play with any children even when prompted, but he does respond to being played with. So, doctor, can you just tell us a little bit more about the developmental assessment, or what we should
Yeah,
do and yeah.
sure. Because this patient has got Down syndrome. So as we all know, Down syndrome patient they have a developmental issue. They either have a global developmental delay when they were younger, and then as they grow older, this will become learning difficulty. So yeah, I mean, I'm not surprised that this child has got global developmental delay, and but I think I'm more interested to know whether even though delay, whether the child make any progress in the development or not, because that will mean more to me. So when you take a developmental history, you have to decide whether this child is having a static phase of development, like the child not progressing, or is it progressing but slow, or is it like progress already quite advanced and then now regress. So you have to decide whether this is a delay or regression or just static. I think this will give us a bit more meaning rather than just a like a what I call that, a point, a single time point assessment. So I will need more history from the mother. If let's say possible, just tell me whether the child has made improvement in the development or not. I think that will probably mean better.
So, doctor, if there is some improvement or some regression, what does that tell us about the patient?
Well, that will mean like different pathology. So of course when you talk about regression in development, then you have to think about diseases that can cause developmental the regression, and of course like Down syndrome there will be delay anyway, but they should be making progress by if let's say we send a child for early interventional program, this child even though delayed making good progress with the occupational and also physiotherapy. So I think this one can tell us more what are we dealing with, whether this is a regression problem or whether this is a delay but making progress. So I think these two are quite different and will lead us to different path as we investigate the disease.
I see. Okay, thank you,
Okay.
doctor. So I will now move on to the second prompt. Before that, anyone have any questions? If you have any questions, please leave them in the message board so we can come back to it later. So I'll move on to the second prompt. So Shahid, tried an 8-month-old infant with underlying tricuspid atresia, ventricular septal defect, and small secundum atrial septal defect, presented to the emergency department with fever for the past 3 days associated with cough. So what do you think, doctor?
Yeah, so again, this is also a complex situation whereby you have a child with a VSD and a small ASD and coming with fever. So you need to know, a fever again is a very common presentation, not just pediatric, also, can be in adult patients. So you need to find out more, lah. For example, is it just fever alone or fever with other symptoms? I think that's the first thing I would do. Any other associated symptoms with this fever and how many days of fever?
Okay, so I'll just talk about the associated symptoms a bit. So the associated symptoms are 2 to 3 days of history of chesty cough, which is intermittent in nature. One episode of post-tussive vomiting with whitish sputum. The cough was not prolonged or barking in nature. The mother claimed that there was some facial congestion, but no cyanosis was observed. So other than this, no other associated symptoms.
Okay, so there's some cough, right?
Yes.
Yeah, so now, with fever and cough, you're thinking more like, whether this is a pneumonia or this is like a URTI. So that, then you probably then expand a little bit more, try to find out, whether the child has got any, if let's say the child cough out sputum or vomited out sputum, what's the color, any sick contact, any previous history of like bad pneumonias, whether the child has got any other respiratory problem in the past medical history. I think all these are important to me. And not to forget, since the child having underlying congenital heart disease, also important to us, whether this fever exacerbate any of the heart failure symptom. Usually, like VSD, ASD, I mean, ASD won't usually cause you to have heart failure, but VSD can. So you need to know whether the VSD, how severe is the VSD, whether the child is on any anti-failure medication, how was the child's activity during the non-febrile time. So when normal time, the child can walk up to 10 kilometers, that's just for example. But now it can only walk 1 kilometer, then become tired already. So this is some worsening iteration of effort tolerance. So you have to also inquire about that.
Okay. So, so doctor, about this patient, you mentioned that he does have some congenital heart disease. Would that point you to a specific, maybe point you to another diagnosis rather than the normal, like normal patients, you might think this is a normal pneumonia. Would this point you to another diagnosis other than just pneumonia? Maybe you think about something more malignant?
So again, you are probably thinking about what? Infective endocarditis? Is that what you're trying to think?
Yeah, something along that lines, yeah.
Yeah, so I think by just taking history, sometimes this can be a bit difficult because you need some examination to see whether there's any new murmur anywhere of the child or something. So I think this one a little bit tricky because you just have to you probably get a bit more information after you examine the child. So just by taking history is of course one of the differential, but you should always try to make a conclusion after you examine the child. This is what I think.
Okay, so since doctor you brought up examination, so I would just like to point you towards the results. So for the patient's cardio examination, general examination is okay, alert, pink on air and moving his limbs actively, no dysmorphic features, looks somewhat thin but not atrophic or anything, hypotrophic or something like that. For his cardiovascular examination, I would just point you towards that the patient had pansystolic murmur of grade 5 to 6 with trills felt at the left lower sternal edge. For the respiratory examination, there are cross crepitation heard at the left lower zone. Peripheral examination, no peripheral cyanosis, no clubbing. Okay, yeah. So what do you
So
think
from your
about this?
examination, yeah, because you heard cross crepitation, that will probably point more towards like pneumonia. And pansystolic murmur is something that we expect from having a VSD, but grade 5 to 6, that's very loud. I haven't heard any grade 5 to 6 murmur in my life, so I mean maybe I haven't lived very long. I mean I don't know, but yeah, that's something very special. But I think with a cost calculation, I will think more towards pneumonia. So I probably get an X-ray done, take the blood to see whether the white cell raised or not, and things like that.
Okay, so doctor, just like to ask you about this since I know there are 3.1 students here. They probably haven't heard enough murmurs or heard enough crepitation. Maybe they have difficulty differentiating between transmitted sounds, crepitation, stridor, wheezing, stuff like that. Can you give some tips and tricks about how we can go about this?
Okay, sure. I mean, I must tell you that, even until now, sometimes I have difficulty to differentiate, which is like transmitted sound, which are like pansystolic or systolic murmur, especially in children, the younger one, their heart rate is so fast, sometimes you can't even, if you just hear like systolic murmur, you cannot even tell whether this is a ejection systolic or pansystolic. So if you ask me, number one, you have to get your basic right first. So last time when I was a student, I used to, go to maybe things like YouTube. But during my time, I mean, there are not so many YouTubes with heart murmur, so I have to go to the library, borrow the CD or tape just to listen a few times. And during ward round, whenever they say, oh, this patient has got murmur, then you try to go and listen and then try to appreciate whatever thing that can appreciate. So I think this is how I learn. First, try to get your basics right. Okay. Try to differentiate, which is pan, which is ejection systolic murmur. And then after that, when you're more confident, go and listen in a real patient. And then whenever they say some pathology, some murmur heard on this patient, try to go and listen and see whether you agree with the diagnosis or not. Yeah, I think that the thing is, you need to learn from the expert. As they hear the murmur, don't be scared. Go and grab the stethoscope and then have a listen also. See whether you hear the same thing or not. And then if you cannot hear, ask them to put the stethoscope on the patient chest and then let you have a listen to what they listen also. This is what I think.
Okay. How about the added breath sounds?
The transmitter sounds and things like that, again, it's the same thing. Now you can go to YouTube. Make sure you go to the trustable source. Don't go into some like non-trustable dodgy site and then listen and get the wrong idea. Go to the proper one and then listen to the murmur. I don't know whether now you all have any like online audio clips that tell you about murmurs. Do you have that in by Merdu or something? I'm not so sure.
I think they do tell us where to go.
So I think just go to the site. Sure. Yeah. So I think as during MCO you can't examine real patient. I think just to go and listen, click and make sure you can tell the difference. So as the the ward reopen after the MCO ends or something, I don't know. You have to use the chance to try to listen to the real patient as much as you can.
Okay, so doctor, last question about the fever. So if for the fever, for how would you approach a child with fever, but let's say there is no associated symptoms?
Whoa, I mean, this is, tough. I mean, so if let's say no, just a fever itself, then you have to really think about the disease that can only, just present with just a fever. So there are many, many possibilities. For example, you can have things like dengue fever, viral fever, up to things like, maybe sometimes you can get, what I call that, leukemia, acute leukemia. Sometimes they just come in with fever, but when you examine the child, or you get things like hepatosplenomegaly, yeah. So of course, number one, whether there are any more symptoms. If no symptoms, how long is the duration? Whether this fever is a constant one, does it resolve with PCM? Is it happen on particular time of the day? And then when you have fever, how high is the fever? Is it just a true fever, or is it maybe the mother say, okay, the thermometer showed 37.1. I thought that's a fever. So always clarify how was the fever confirmed. Was it like thermometer or just by touch on the forehead? And how long has it been lasting for? And then how frequent does it resolve with PCM and things like that. Sometimes as you go a bit further, I mean, you can pick out some subtle association symptoms, if you are careful enough, or maybe the child has got some mild watery stool that mother thought it was normal. Then you keep asking, or when the mother say normal stool, always try to clarify what is the consistency, and whether there's any change in color or not. Mother say, oh, I never changed his stool. Then you ask the child, or suddenly he say, oh, it was like a bloody stool. So I think you should always go back, verify the things that mother claim to be normal, and then whether they're true normal or not. This is what I think.
Okay. Okay, so there are 10 minutes left. Maybe I'll stop with the case discussion, open the floor.
Okay.
I noticed some some messages.
Okay.
Okay, so doctor, do you want to answer these questions first, or do you want to let the people voice out?
Yeah, so I think maybe I can try to answer some questions first. I mean, if it's okay, so I think I can also look at the question here. So, okay, so Kai Xiang asked about, okay, what is the commonest sort of like genetic disorder in children? I don't know whether Hai Liang you know the answer, but I think in Malaysia, when you talk about like genetic disorder, gene disorder, the commonest will be, what do you think? Thalassemia. Yeah, thalassemia is sort of like a common one. So you probably have to read a bit more about thalassemia also. Okay, then Hamzatu created some meeting notes. Okay, then Ling Yi, would a patient with seizure have an effect on development of the child? And in which case would this history of developmental delay help in the diagnosis of epilepsy? Okay, of course, if you have an uncontrolled seizure, like when you have a seizure, not you, I mean when a child has a seizure, there's a lot of abnormal brain activity, abnormal brain wave discharges in the brain. That will, of course, number one, if let's say the seizures occur very frequent, it will affect the quality of life, it will affect the sleep quality, which will most of the time will have some impairment on the child's development. So that's no doubt. Okay, so in which case this history of developmental delay help in the diagnosis of epilepsy? Of course, you have to know whether the child, I mean, in what way does the epilepsy affect the child? So for example, like the child was growing normally, suddenly have this epilepsy, and then start to have delay or even regression. So there's some form of epilepsy syndrome that associated with developmental regression. But I think that will be a little bit too advanced to teach you all at this stage. I mean, if you're interested, you can go and read epilepsy causing developmental regression. But this is the reason why we need to ask about development history in the patient with epilepsy. Okay, so use YouTube and adjust the speed to ×2. Okay, not so sure what Yang Qun trying to say. Okay, so Grace asked something. Does every patient with first presentation of seizure warrant EEG and imaging? Wow, so I got a lot of neurology question. So you have to see. So go back to your diagnosis of epilepsy. When do you diagnose epilepsy? So the traditional, I mean, conventionally is like 2 or more epileptic seizures. Then you can say the patient having a diagnosis. But for someone with a risk factor to have an epilepsy, for example, cerebral palsy, you probably will investigate the patient with an EEG and imaging, for their first seizure. And then it depends what is the other associated problem. For example, if a patient presents with first seizure with severe global developmental delay, you probably will straight away investigate the patient with an EEG and imaging if you are thinking something is causing this problem. So I think it has to see what is the problem that the patient has. So if a child is having normal development, there's normal neurological findings, and then first seizure, we probably just observe first, unless you get some focal neurology, you get some developmental problem or learning difficulty, then I will be more aggressive in getting an EEG and neuroimaging. Okay, so I think Theo answered the question, thalassemia. Okay, that's correct. Any more questions?
If anyone wants to ask any questions, they can just unmute or raise your hand.
Yeah, but if you're too shy, you can always leave your message. Maybe I'll just go on and give you the tips of passing pediatric. This is what I think, okay? So rule number 1, okay, this is also applicable for all the specialties, Don't learn it just for the sake of passing the exam. This will make the learning very dull, very boring, and then you won't enjoy learning anymore. And then, this one, be positive with the pediatric posting. Don't trust the hearsay from your seniors. Pediatric posting, in UMMC can be fun. It's not very strict. We are very, I don't know what you think of pediatrician, but don't trust the hearsay. It can be fun. It depends how you see it. Okay, learn the basics before you move on to the advanced topic. So, for example, just now, Ling Yi asked me, what sort of things associated with a developmental problem, what sort of epilepsy can have a developmental problem. So before you move on to the advanced topics, you have to learn the basic, how to take the seizure history right, before you learn the advanced one, because otherwise, there's no end of your learning. You keep going deeper and deeper to the extent that you are very stressed. Okay. Yeah, I'll give you an example later. Okay, so don't be afraid to say you don't know, and be brave to ask questions, especially during the consultant round. You're not an SOL on the ward. I heard students saying that, oh, I'm a space occupying leisure. I feel that I'm not welcome in the ward round. So I think it depends how you present yourself. If you always say, oh, I don't know, I mean, you're very scared to ask questions. Of course, people won't notice you, but of course, you don't ask silly questions lah. I mean, although I want to say no questions are silly, but some people, they don't try to catch people's attention by asking some unnecessary questions. I think that also not very nice. Okay, so you have to be rational. And the last thing is, practice, practice, and practice. By doing things 1,000 times, you'll be the master of doing that particular thing. So this is probably what I want to share with you during this session. And to give you a summary, I have talked to you about the importance of good history taking skills. And pediatric history, how do we approach it, with a general template and a system-based approach. History taking can be enjoyable if you know what you are doing. Of course, you are forced to take history, you won't find enjoyable. And don't learn pediatrics just because you want to pass the exam. Learn it because it's not to be missed in your medical career. After all, about 1/3 of the population are children. So, no matter how as a doctor, you come across with pediatric patient at some point of your career. So with this, I end my session today. So any questions, you can drop me an email, or you can find me on Microsoft Teams. This is my username, I think. Yeah. So I welcome any questions, comments, or suggestions that you have. Yeah. So I don't know. Shall I check, see whether any more questions? Okay. Wow. Okay, so Suzy, if the child presented with seizure did not regain consciousness from the first seizure to the second, does it consider a standard epilepticus? Yes, any seizures that what we call that 5 minutes or longer, you can call it a status epilepticus using the latest definition of status epilepticus. And if the child doesn't regain consciousness, you have to decide whether there's any ongoing seizure, or is it just a post-ictal drowsiness. Sometimes that can be a bit difficult. I think most of the time in emergency, people just assume this is status epilepticus and then they just treat accordingly. But it can be due to just a post-ictal drowsiness. How do we differentiate? It can be very difficult. Sometimes you may need EEG to help you to decide. So I think this is a difficult situation. So meaning after the first seizure, which lasted 5 minutes, child did not regain consciousness after a few minutes. So I think this one, it really depends, you have to see whether the child is just really sleeping or really, not conscious with blank staring and not moving. I think that will point more towards a status. But if the child closes the eyes, appear to be drowsy or sleeping, very hard, it can be due to ongoing seizure. It can also be due to post-ictal drowsiness. So in which case, if you're not sure, you want to treat as status, I mean, you can, but it depends what the doctor thinks at the time. So it's kind of difficult. Yeah. So
with that, I think there should be no more questions. Are there more questions?
Yeah. Okay.
Oh, there's one more.
One more question. So Shana, how do we rule in failure to thrive in a mouth? Okay. Oh, that means the child is okay. How do we rule in failure to? So that means if you see the child for the first time and then you think the child is having failure, so you just have to see which centile. Okay, for example, if the child is 2 years old, you have to see which centile was the child, and then and compare it against the birth weight. And then usually the birth weight sort of determines your subsequent centile. You should go along your potential, and of course you have to look at the child as a whole. Look at the muscle bulk, look at the subcutaneous fat. If the child is like skin or bone, okay, no doubt that one no need to do anything. That is a failure to thrive already. But if the child is otherwise good muscle bulk, subcutaneous fat also reasonable, and if the child is like third centile, you have to see whether the child was born small or what. Why was the child having a weight or height at the third centile, even though the patient doesn't look wasted. So I think this one you have to see. This is what I think. I don't know whether I answer all your questions correctly or properly. If you think I haven't answered your question, you can always just ask me again. Okay, thank you. I mean, it's my pleasure to answer your questions, Sochana.
Okay, so I think with that we can end the session. Thank you, Dr. Lim,
Thanks
for
everyone.
attending, teaching us with your knowledge. So with that, we will end this. So next week we will probably have another session with Dr. Ong from ID. I hope to see you guys there. Okay, thank you, Doctor. Thank you, guys.
Okay, thanks everyone. Okay, stay safe.
Okay, bye-bye.
Bye.
Thank you, Doctor.
Thank you.
Thank you, Doctor.
Thanks, Doctor.
Thank you, Doctor.
Thank you, doctor.
Thank you, Doctor.